You're a dentist, and well, every day you face these really crucial, sometimes pretty high stakes decisions. You've got a patient in the chair. Maybe they're describing this, nagging discomfort comes and goes. Or maybe it's something much more acute, that persistent throbbing pain that keeps them up all night. Is that toothache a simple reversible thing? A pulpitis we can maybe handle with a straightforward restoration, save the nerve? Or are we looking at something more serious, something deep-seated, irreversible damage to the pulp that means, well, a root canal is the only way to save the tooth itself? These aren't just academic questions, right? These are the practical day-in, day-out dilemmas that really underpin so much of what you do. They directly impact patient comfort, the tooth's long-term survival, your whole treatment plan, really. So today we're taking a deep dive, a really deep dive into a, frankly, profoundly important systematic review. This isn't just some paper you glance at. It's a meticulously crafted analysis published back in 2012 in the International Endodontic Journal, led by Mejàre and a team of researchers. And their mission. It was, well, incredibly ambitious, but so relevant to your daily work. They set out to meticulously appraise the diagnostic accuracy of the very signs, symptoms, tests you use every single day, trying to figure out the true underlying condition of the dental pulp. In teeth affected by deep decay, trauma, other injuries. They cast a really wide net looking at research from 1950 all the way up to 2011, hunting for the strongest evidence for our diagnostic tools. And here's where it gets really compelling, maybe even a bit challenging to some long-held beliefs. Their comprehensive analysis, drawing from decades of research, well, it might just shake some foundations. The overall conclusion for many, many of our common methods, insufficient evidence. That's a pretty stark statement, isn't it? Kind of unsettling, maybe. It makes you ask, well, if the scientific backing is insufficient, what does that really mean for the decisions you're making right there in the moment for your patients? Let's unpack this together. Let's look at exactly what they found, how they got to these conclusions, and crucially, why these findings matter so profoundly for your clinical practice right there at the chairside.
That's right. And it's genuinely hard to overstate just how critical accurate pulp diagnosis is. It goes way beyond just relieving pain, although obviously that's a primary concern, absolutely. But the real imperative, the sort of foundational goal, is making the right treatment decision. We absolutely have to know, as definitively as possible, is this pulp vital or necrotic? Is it alive or dead? But maybe even more nuanced, and often, frankly, much more challenging, is that distinction within vital pulps. Is it reversibly inflamed, meaning, it can heal, return to health with some conservative treatment? Or is it irreversibly inflamed, signaling damage so extensive that it just can't recover? It's inevitably going to lead to necrosis if you don't intervene. This can it heal question. It's fundamental. It dictates everything that follows. Is the pulp salvageable? Can we do conservative treatment? Maybe vital pulp therapy like capping or a pulpotomy, something that aims to keep the tooth's natural vitality going for years. Or is the damage just too widespread, too irreversible? Is root canal treatment the only viable path to save the tooth long-term, prevent infection? That specific decision point, it dictates the immediate outcome for the patient, profoundly influences the tooth's long-term survival, and it can really impact their overall quality of life, avoiding pain, further complications. It's the difference between potentially a simpler, less invasive procedure and, a complex multi-appointment treatment. And it's so important to remember, a definitive diagnosis is hardly ever based on just one single finding. It's almost always, like the review highlights, a set of observations. You're gathering data points, right? The patient's chief complaint, their history, listening carefully to how they describe the discomfort, any history of trauma. Then there's the thorough clinical exam, evaluating test results, and of course, looking at the radiographs. The whole clinical picture can be incredibly complex. You get overlapping symptoms, signs. It means getting to the right diagnosis, and the best treatment often requires a diagnostic process consisting of several steps. It really is like a multi-layered puzzle, and you, the clinician, you're trying to put all those pieces together in real time.
Yeah, and before this specific systematic review, it really felt like there wasn't a clear, agreed-upon consensus. On which diagnostic method or maybe combination of methods was truly the most accurate or even reliable. I mean, we all have our go-to techniques, right? What we learned, what we've seen work or seem to work in our own hands. But previous attempts to kind of synthesize all this knowledge were mostly what you'd call narrative reviews. They discuss things, summarize literature, sure, but often without that really strict, quantifiable, transparent methodology you see in a proper systematic review. This team, Mejàre and colleagues, they really set out to bring that kind of rigorous scientific appraisal to these fundamental questions at the very core of endodontics. They weren't just summarizing what people had said before. They were deeply, critically looking at the quality of the evidence itself.
And their methodology was, you're absolutely right, exceptionally rigorous. which is precisely why their findings carry so much weight. They started with this incredibly comprehensive electronic literature search, casting a really wide net across the major databases: PubMed, Embase, Cochrane's Central Register of Controlled Trials, Cochrane Reviews, all the big ones. Their search covered a huge time frame, diligently going from January 1950 all the way up to June 2011. And they did a complementary search right at the end there, June 2011, just to make sure they caught the absolute latest stuff available then. And to be as broad as possible, they even stated that all languages were accepted, provided there was an abstract in English. That really shows their commitment to being exhaustive. But the funneling process they used, wow, it vividly highlights just how scarce, truly high-quality, directly relevant research is in this specific area. They started with an incredible 2,131 abstracts. Just imagine wading through all that. From that massive initial pool, they meticulously screened and narrowed it down to 155 full-text articles, read and evaluated in detail. And finally, after applying their really strict, pre-specified inclusion criteria, only 18 studies, just 18 ultimately fulfilled those rigorous standards for quality and relevance.
18 out of over 2,000.
Yeah, exactly. That number, 18 out of 2131, it's really striking. And it immediately underscores this profound challenge, finding robust, high-quality evidence in such a critical area of dentistry. Now, a crucial point for context for you listening, and the review notes this explicitly. Radiographic methods were not included in this specific review. The authors explained this was thoroughly covered in a separate dedicated article. So for our deep dive today, we're focusing purely on the clinical signs, the symptoms, and the physical tests for figuring out pulp condition. To really rigorously assess the quality of the studies that did make the cut, they used two internationally recognized sort of gold standard tools. First, for looking at individual articles, they used the QUADAS tool. That stands for Quality Assessment of Diagnostic Accuracy Studies. This tool helped them systematically rate each study: high, moderate, or low quality. Now, when they said high quality, they were looking for specific things, like were patients randomly or consecutively selected, were they adequately described so you know who was studied. Crucially, did the index test, the test being studied, like EPT, did it form part of the reference standard itself? You want to avoid that circular reasoning. And maybe most importantly, were the examiners blinded? Meaning, did the person interpreting the test know the actual diagnosis, or vice versa? That blinding is absolutely vital to minimize bias, which can unconsciously inflate the results. Then, to rate the overall quality of evidence across all the studies for a particular method, they use the grade system, another internationally recognized approach. Grade gives you 4 levels: high, moderate, limited, or insufficient evidence. Essentially, grade trying to answer a really practical question for you, the clinician: how much confidence one can have in a particular estimate of effect. Is this diagnostic finding, built on solid ground? Or is it pretty likely that new research down the road will change the picture? It's about certainty. And here's the stark reality that came out of their quality assessment, the finding that really sets the stage for everything else. No study reached high quality. 2 were of moderate quality.
Wow.
Yeah.
Just wow.
Yeah. Think about that. Out of all 18 studies that even got through the filters, only 2 were rated moderate quality, and none 0 were considered high quality. That immediately tells you something profound, maybe even humbling, about the existing scientific foundation for so many of our everyday pulp diagnostic methods.
Okay, that is a truly sobering statistic right off the bat. No high-quality studies at all. So, with that incredibly rigorous framework and that, rather stark finding about the overall research quality, let's turn to what Mejàre and the team actually found. What about those clinical signs and symptoms we often rely on so heavily? The patient's description of pain, how they react to hot or cold, even tenderness to percussion. What was the verdict on those daily observations, the subjective stuff we get from patients?
Right, and this is where the conclusions are particularly impactful, because they really do challenge a lot of common assumptions, a lot of clinical intuition. The main overarching conclusion was that the review found insufficient evidence. They rated it using grade. Insufficient evidence to assess the value of toothache or abnormal reaction to heat-cold stimulation for determining the pulp condition.
Insufficient evidence. Again, that's huge.
It is. It implies the scientific backing for these everyday tools is just much weaker than many of us might think. It doesn't mean symptoms are worthless, but their accuracy in pinpointing specific pulp conditions, that hasn't been rigorously proven. Let's dive into the specifics a bit, especially from the study that kind of stood out. Out of the 11 studies in this category looking at signs and symptoms as indicators of pulp inflammation, an incredible 10 were low quality. The only moderate quality study directly addressing this was by Hasler and Mitchell, published way back in 1970.
1970, that's quite a while ago.
It is. And their study was pretty unique. It involved 47 asymptomatic teeth with deep caries. These teeth were later extracted for various reasons, which allowed for histological examination of the pulp. That was their reference standard. The truth: direct histological confirmation is key. And what did Hasler and Mitchell find? First, and this is quite counterintuitive for many of us, there was no obvious association between any of the test results: cold, heat, EPT, percussion, and the inflammatory condition of the pulp.
No obvious association between our standard tests and the actual inflammation.
Exactly. Think about that. It directly challenges that assumption that a specific response reliably tells you about a specific inflammatory state. Second, regarding percussion tenderness. It occurred in 80%, 37 out of 47 of the teeth, without regard to the inflammatory status.
80%, regardless.
Right. So a tooth being tender to percussion just wasn't a reliable indicator of whether the pulp itself was inflamed or healthy. It was just there most of the time. Maybe it relates more to periapical issues, not the pulp itself. Third, and this is a really surprising finding about thermal response, all teeth having minimal or no pulp inflammation responded abnormally to either cold or heat provocation or both.
Wait, all the healthy or minimally inflamed teeth responded abnormally to hot or cold?
According to this moderate quality study, yes. It suggests that a painful response, or what we might interpret as an abnormal response, which we often take as a clear sign of irreversible pulpitis. Well, it doesn't automatically mean severe inflammation. Even healthy or minimally inflamed pulps showed these reactions.
That really forces us to rethink how we interpret our thermal tests, doesn't it? That's a bombshell finding, especially that last point. I mean, so many of us were taught, hang your hat on thermal sensitivity as a key indicator. How do we reconcile this lack of strong evidence with the clinical intuition we've built up over years? Does the review give any clues about why our intuition might sometimes be so different from the scientific backing? Especially given that, 28% of those asymptomatic teeth in the Hasler and Mitchell study still had significant inflammation.
You really hit on a major point of, cognitive dissonance for clinicians. And the review indirectly addresses it by constantly highlighting the poor quality and the methodological problems in so much of the research. Our clinical intuition, it's built on years of experience, countless patient interactions, observed outcomes, and that's undoubtedly valuable. Of course it is. But experience alone, without that rigorous, unbiased scientific validation, can sometimes lead to things like confirmation bias, where we tend to interpret things in a way that confirms what we already believe. The issue here isn't necessarily that our individual gut feelings are wrong every time. It's that they haven't been proven right consistently under controlled, unbiased conditions across a wide range of patients. This review just forces us to acknowledge that pretty significant gap in our high-level evidence. And let's emphasize that crucial clinical takeaway from Hasler and Mitchell again. Absence of painful symptoms such as toothache did not exclude the presence of a severe inflammatory involvement of the pulp. To put that number on it again, a striking 28%, nearly a third of these asymptomatic teeth, the ones with no reported pain at all, still had moderate or severe pulp inflammation when they looked under the microscope after extraction.
So a patient could feel nothing and yet have a seriously diseased pulp.
Precisely. That's a profoundly challenging finding for relying on the absence of symptoms as a sign of health. It means you could easily have a quiet but deeply diseased pulp sitting there. They also noted, though the sample size was small, that moderate to severe inflammation was more frequent in teeth with calcareous pulp exposure. 71% of those teeth had it, compared to those without exposure. But again, small sample, so handle with care.
So if I'm getting this right, it sounds like while some, lower quality studies might hint at certain symptom combinations, like that feeling extruded plus constant pain maybe points to necrosis, or bursts of pain suggest vitality, the moderate quality evidence, the stuff we should probably trust more, really suggests we just can't confidently rely on pain alone, or even those common responses to thermal and percussion tests to accurately diagnose the inflammatory status of the pulp. That really does fly in the face of a lot of what we learned or experienced day to day.
Exactly. The stronger evidence says, be cautious. Be very cautious interpreting subjective symptoms and even those common test responses when you're trying to pinpoint the inflammatory state. Now, there was a little bit of discussion, though it came from a low-quality perspective study by Matsuo et al. Back in '96. It looked specifically at pulp capping outcomes. That study suggested that pulps with profuse and lingering bleeding had a significantly poorer outcome than those with modest bleeding or a bleeding of short duration.
Okay, so the type of bleeding might be a clue.
It might be, if you're directly looking at the pulp, say during a capping procedure. This could be a specific, but weakly evidenced clinical marker to note, the character of the bleeding, not just its presence. Interestingly, that same study found preoperative pain of minor intensity did not affect the success rate. So a little bit of pain beforehand didn't seem to predict failure in their pulp capping cases. But again, always remember, low-quality study, we can't build solid clinical guidelines on it, but it's an interesting observation, maybe for future research to explore properly.
Okay, that's a ton to digest about symptoms and our traditional clinical observations. Given all that ambiguity around subjective stuff, and even things like percussion, it really begs the question, what about our objective tools, the ones we plug in or spray cold on? Are they any more reliable? What did this systematic review find about where our diagnostic tools for assessing vitality really stand?
Well, unfortunately, the overall conclusion for these more objective vitality tests pretty much mirrors what we saw for signs and symptoms. Again, the evidence base is also insufficient to assess the accuracy of electric or thermal pulp testing or methods for measuring pulpal blood circulation to determine whether the pulp is vital or non-vital.
Insufficient evidence. It's the theme of the day.
It really is. It underscores this fundamental lack of robust data across the board. Let's break down the findings for each type of test. And remember, the gold standard here is often direct visual inspection of the pulp or histology. For electric pulp testing, EPT, there was only one moderate quality study included. That was the Gopikrishna et al. Study from 2007. It was reasonably well designed. 80 patients, single-rooted teeth, deep caries, or needing endo for other reasons. They used direct visual inspection of the pulp after exposure as their reference test, a good direct measure. Their findings. EPT correctly identified 71% of the necrotic pulps, sensitivity, and 92% of the vital pulps, specificity.
Okay, so pretty good at confirming vitality specificity, but maybe less good at picking up necrosis sensitivity.
Exactly. High specificity means if it gets a response, the pulp is likely vital. Lower sensitivity means if it doesn't get a response, it might still miss some necrotic cases. Looking broader at the other, lower quality studies on EPTD generally showed high specificity, 90%. Again, good at confirming vitality. But the sensitivity varied substantially. The range was huge, 21% up to 87%.
Wow, 21%. That's barely better than a coin flip for catching necrosis in some studies.
Right. So while ETT seems reliable for telling you a pulp is vital if it responds, it's much less consistently accurate at telling you a pulp isn't vital if it doesn't respond. And often, that's the more crucial question, isn't it?
That difference between sensitivity and specificity is just so critical for us clinicians, isn't it? It dictates how we use the test result. So, EPT, good. Yes, it's alive, but not always reliable for, no, it's dead. What about the cold test? That's another absolute go-to in pretty much every dental office.
Absolutely. Understanding the distinction is crucial for interpreting these results in your practice. High specificity, low sensitivity. Fewer false positives, saying it's dead when it's alive, but potentially more false negatives, missing a dead pulp, thinking it's okay. For the cold test, that same moderate quality Gopikrishna et al. 2007 study using tetrafluoroethane, they found the cold test correctly identified pulp necrosis in 81% of the teeth sensitivity and vital pulps in 92% specificity.
Pretty similar numbers to EPT in that study, actually. Quite balanced.
In that one study, yes. But again, looking at the other included lower quality studies, the picture gets muddier. Specificity for various cold tests ranged really widely, from a mere 10% up to 98%, while sensitivity, with one exception, generally reached 75%.
So again, maybe better at confirming vitality with a response, but that wide range in specificity across studies, that's concerning.
It is. It might be due to different techniques, different cold agents, different patient groups. It just underscores the variability and lack of consistent high-quality proof. And then the heat test. The review found 6 studies looking at its accuracy, every single one, low quality. And they reported highly variable values of sensitivity and specificity, just all over the map.
So heat tests, basically unreliable based on this evidence.
That's what the current evidence synthesis suggests. It's just too inconsistent across the low-quality studies to draw any firm conclusions.
Okay, so if the individual tests all have these limitations, these question marks around their evidence, does combining them help? Is more actually better when it comes to pulp testing? That's certainly something many of us do, almost intuitively.
It's a very logical thought process, and yet 2 studies did look at combining tests. One by Seltzer et al. From 1963. Again, low quality, found that combining cold and heat tests did increase specificity compared to using each alone, but sensitivity decreased.
So a trade-off. Better at confirming health, worse at detecting disease.
Yeah.
Not necessarily what you want.
Exactly. Not ideal if your main goal is to catch all the necrotic cases. The other study, by Weisslitter et al., in 2009, also low quality, suggested maybe some improvement. They found the combination of cold test, carbon dioxide and endo-ice, and EPT improved the ability to correctly identify necrotic pulps. Sensitivity ogres 96%, and vital pulps, specificity 92%.
Okay, those numbers look really impressive. 96% sensitivity, 92% specificity. That sounds great.
They do sound great, absolutely.
Yeah.
High sensitivity and high specificity is the holy grail. However, the critical caveat, noted right there in the systematic review, is that both studies have methodological shortcomings.
There's always a catch with the low-quality studies.
Pretty much.
Oh.
So while combining tests might hold promise, the high-quality evidence rigorously proving this approach is still severely lacking. We just can't draw firm conclusions from studies with known flaws.
Thinking about this, if we're really trying to determine actual vitality, beyond just nerve sensation, shouldn't we be looking directly at blood flow? That feels like the ultimate undeniable indicator of whether tissue is alive or not.
Absolutely. That's the physiological truth, isn't it? Blood flow equals life. Nerves can sometimes be tricky alive, but unresponsive, maybe damaged, but still firing. But blood flow is more definitive. And yes, methods like laser Doppler flowmetry, LDF, and pulse oximetry aim to do exactly that, assess the vascular supply, the true vitality, not just nerve sensibility. For laser Doppler flowmetry, LDF, 2 low-quality studies included in the review did report very high sensitivity, 88 to 100%, and specificity, 100%.
Wow, nearly perfect accuracy. That sounds amazing.
It does sound amazing on the surface. But, you guessed it, the review points out the crucial caveats. Both studies suffer from methodological shortcomings, end quote. And beyond the study quality, LDF has practical issues. It's expensive and requires technique-sensitive equipment, not exactly something you can easily whip out chairside in every practice. It can also give variable and uncertain results if the conditions aren't highly standardized. Needs a very controlled setup, plus a major limitation. It's useful only in teeth with a pulp chamber positioned well above the gingival margin. So forget using it easily on teeth with crowns or significant recession. That really restricts its applicability. Now, pulse oximetry. This one yielded particularly impressive results in that moderate quality Gopikrishna et al. 2007 study, the same one we keep coming back to. That study showed pulse oximetry correctly identified all non-vital pulps, so correctly 100%, and almost all vital pulps. Specificity, 95%.
100% sensitivity. It didn't miss a single non-vital pulp.
According to that study, yes, those are striking numbers, highly promising, suggesting it could be a really powerful tool. However, the overall evidence for pulse oximetry is still rated as insufficient.
Why, if the numbers were that good?
Because that remarkable result is based largely on just that one moderate quality study. Science needs replication. We need more consistent high-quality research from different teams confirming these excellent results before we can confidently say, yes, this is a universally reliable method. And like LDF, it also has the practical limitation. It's limited to teeth with pulp tissue well within the crown portion of the tooth. So still not a perfect solution for every clinical scenario.
Okay, before we zoom out to the bigger picture, you mentioned a brief note on other clinical markers. Things like sensibility to probing exposed dentin or seeing a widened PDL on the radiograph. One low-quality study reported perfect sensitivity for these. Sounds almost too good to be true, right? If they're that accurate, why aren't there our main diagnostic tools? What's the catch?
That's a really astute question. And you're right, on paper, those numbers from the Kamperud-Lundpexoid 2005 study do look remarkable. Perfect sensitivity and relatively high specificity, 76 to 80%, for probing exposed dentin or seeing a widened PDL space. Sounds fantastic. Perfect sensitivity means it supposedly caught every single diseased pulp. But as the review itself immediately points out, it was a low-quality study with several methodological shortcomings.
There it is again, the quality issue.
Exactly. It highlights perfectly why those quality assessment tools, QADAs and GRADE, are so incredibly important. High reported accuracy from a flawed study, it can be seriously misleading. Maybe their patient selection was biased. Maybe the interpretation of the reference test wasn't truly independent. Who knows? It's not that these signs are necessarily false clinical observations. You see a widened PDL, you note it. But the scientific rigor just hasn't been applied to prove their diagnostic value in a way we can confidently generalize to every patient walking through your door. In some things, like intentionally probing exposed dentin just for diagnosis, well, that raises ethical questions too, doesn't it? Especially in asymptomatic teeth. That further limits its use as a routine marker. So, while interesting observations, the actual evidence for these markers remains very weak. In essence, even when we look at the objective tests, the ones that promise more quantifiable results, the evidence base is surprisingly weak. It consistently leads back to that same conclusion, insufficient evidence, for most of our standard pulp diagnostic methods.
So, okay, if the scientific evidence for so many of our, well, bread and butter diagnostic methods, the things we literally do every single day, multiple times a day, is consistently being called insufficient, why? What are the underlying problems here? The systemic issues in the research landscape for pulp diagnosis, it can't just be that nobody's tried to study it. Clearly, people are doing research.
That's an excellent and absolutely crucial question. And the review really digs into these methodological and practical challenges in its discussion section. The authors pinpoint several fundamental root causes for this weak evidence base, and they're quite profound. They really impact how we should interpret almost all the existing research in this field. One of the biggest hurdles, maybe the biggest, is the lack of a good reference test. That gold standard we need for comparison. For the pulp, the ideal reference standard, the absolute truth about its inflammatory status, is histological examination. Looking at the tissue under a microscope, seeing the cells, but just think about the practicalities. It's ethically very difficult and often just clinically impractical to extract healthy teeth, or even teeth that could potentially be saved conservatively just for research purposes to get that histology sample.
Right, you can't just pull teeth for science anymore.
Exactly. The review notes that formerly such teeth were frequently available. They got pulled for caries instead of treated, or sacrificed for bridges. But today, access to such teeth is highly limited because we have better treatments, more conservative approaches. This makes getting that direct, definitive histological confirmation really, really challenging in modern ethical research, especially across the whole spectrum: healthy, mildly inflamed, irreversibly damaged. So researchers often have to use less definitive reference standards, like maybe clinical outcome after treatment, which then compromises the accuracy studies themselves. It's a built-in limitation. Another major issue: outdated and poor study designs. The review points out that most of the included studies were simply out of date. They reflected an older era of research methodology before the really rigorous standards for diagnostic accuracy studies, like quadas, were widely established or followed. Plus, there's been this over-reliance on cross-sectional studies taking measurements at just one point in time. The benefit of a prospective study design, where you follow patients over time to see how things evolve, how the test predicts outcomes, that was often not considered.
Only one prospective study out of 18, you said.
That's right, only one. This really limits our understanding of the dynamic nature of pulp disease and how tests perform over time or at different stages. A single snapshot doesn't tell the whole story. And then we get to the crucial bias issues. These plague so much of the literature, and they're really important for you, the clinician, to grasp, because they can make tests look much better on paper than they are in reality. First, case control bias. Lots of studies use this design. The review explains it tends to overestimate diagnostic accuracy. Why? Because these studies often compare a really clear-cut group of diseased teeth cases against a really clear-cut group of healthy teeth controls. These groups are often much more distinct than the messy middle ground you see in your typical unselected patient pool. This clear separation just makes the diagnostic test appear more accurate than it truly is when you try to apply it to those ambiguous in-between cases you face every day. Second, spectrum bias. This one is super common and really critical for thinking about generalizability to your practice. Many of the studies use samples of referred patients or teeth scheduled for endodontic treatment or extraction. What that means is the study populations were often skewed towards more severe cases, more obvious disease, or maybe just perfectly healthy controls. This kind of sample may not represent patients who would be exposed to the test in daily clinical practice.
Okay, hold on. So if I'm understanding this right, it means the results of a test might look, say, 90% accurate in a study. But that could be wildly different when I use it in my clinic, because my patients are all over the map, condition-wise, whereas the study population wasn't typical. Maybe they'd already been sort of pre-screened or only included the really obvious cases. Does that mean the test itself is less accurate, or just that the study didn't truly capture its real-world performance?
You've absolutely hit the nail on the head. And it's such a critical distinction for clinicians. The test might be accurate in those very specific, maybe extreme populations used in the study, but its real-world performance on the full spectrum of ambiguous cases you see every single day, it could be much, much lower. Imagine, like you said, a study only using teeth with huge abscesses versus perfectly healthy teeth in young people. A test might look great differentiating those extremes. Most tests would. But then you take it to your clinic. You're trying to figure out, is this mildly inflamed pulp going to make it, or is it moderately inflamed and needs an RCT? The symptoms are vague. Suddenly, the test's real-world performance might plummet compared to what the study suggested. That artificial inflation of accuracy, that's exactly what spectrum bias does. The review really emphasizes this. A careful description of the patient spectrum and how they are selected is crucial. Without that, you simply can't know if it's acceptable to generalize the results to your own diverse patient base. Third bias, workup bias. This happens when, maybe, vitality testing may also already have been performed before referral into the study. If patients have already been partially diagnosed or screened before they even enter the study, then, as the review puts it, the value of the test is partly used up. End quote. The test isn't being applied to a truly fresh, unselected group. This can also lead to overestimating accuracy because the study is testing the test on a population that's already been somewhat narrowed down. It can make the test look better than it would in a completely naive population. Moving beyond the traditional clinical tests, the review also took a quick look at biological markers, things like inflammatory mediators, prostaglandins, TNF-alpha, substance P, MMPs.
Stuff you might find in the pulp fluid itself.
Exactly. These substances may indicate pulp status and have the potential to predict the outcome of treatment. They seem incredibly promising for a more objective future diagnosis. But the stark reality from this systematic review, they found no study satisfying the inclusion criteria could be identified to rigorously prove their diagnostic value in a clinical setting. Zero. The only included study that even touched on this, way back in 1965, looked at white blood cell counts from pulp exposures. And it correlated poorly with inflammation, only 36% sensitivity, 64% specificity. So, despite all the theoretical promise, diagnostic value of these biological markers, still largely unproven by high-quality evidence. They're very much still in the research lab, not ready for routine clinical use with validated accuracy. And finally, maybe the most damning indictment of the existing literature overall. The review meticulously details these pervasive methodological shortcomings across almost all the included studies. They even included a figure in the paper, Figure 2, showing just how few studies met basic quality criteria. It's quite revealing. Let's run through some of the biggest ones, because these are why so much evidence gets labeled insufficient. The population was inadequately described in nearly all studies. Huge problem for knowing if it applies to your patients. If you don't know who they studied, how can you generalize? Only one study used consecutively chosen patients. We talked about that non-consecutive selection tends to overestimate accuracy due to selection bias. You need all eligible patients, not just a convenient few. In half of the studies, the index test and reference tests were insufficiently described. Monumental issue for reproducibility. If you can't tell exactly how they did the test or confirm the diagnosis, how can you trust or build on the results? Few studies had two independent assessors of the reference test. Big risk for biased assessment. If one person does the test and confirms the diagnosis, they might unconsciously see what they expect, maybe the most serious. It was usually not possible to discern whether the reference test was interpreted independently and without knowledge of the results of the index test. That's the blinding issue. Massive source of bias.
If the confirmer knows the test result, they might lean towards confirming it, hugely overestimating accuracy. It's fundamental. And lastly, precision. UNG confidence intervals of point estimates was not reported in any of the studies. This is crucial. Without confidence intervals, you don't know how reliable those sensitivity specificity numbers are. Is that 92% really precise, or could it actually be anywhere from 80% to 100%? Without that range, the numbers are much less useful for decision making.
Wow. That really paints a very comprehensive and, honestly, a rather humbling picture of why the evidence keeps coming back as insufficient. It's not just that there aren't enough studies, it's that there are fundamental, pervasive flaws in how the studies themselves were designed, how they were conducted, how they were reported. This all points to just a massive, pressing need for better research, doesn't it? More rigorously designed studies in endodontic diagnostics, especially if we want to move beyond relying so heavily on clinical intuition alone. They even mention specific guidelines researchers should follow, like STARD for diagnostic accuracy studies, CONSORT for clinical trials. It feels like a clear roadmap for the path forward, right?
It absolutely is a clear roadmap, and it highlights that these challenges are systemic. They're rooted in how research in this area has traditionally been done. The authors state it plainly. There is a great need for improvement in the design, conduct, and reporting of studies on diagnostic methods in endodontics. End quote. They emphasize that these existing robust guidelines like the START initiative, standards for reporting of diagnostic accuracy studies, and the CONSORT statement for clinical trials, they need to be widely adopted and strictly followed in future work. These guidelines are designed to ensure transparency, to reduce all those biases we've been talking about, and ultimately to improve how interpretable and generalizable study findings actually are. Without that kind of concerted, discipline-wide effort to dramatically up the quality of the research, we're likely to just stay stuck in this state of insufficient evidence for so many critical diagnostic questions, perpetually operating in that gray zone where intuition and experience kind of have to carry the day because the definitive science isn't quite there. It's a really powerful call to action for the entire dental research community, urging them to build a much more solid, reliable foundation for clinical practice. So the next generation of dentists can rely on evidence that's truly robust. So let's sum up. Our deep dive into this Mejàre IA systematic review, it really highlights a profound, maybe somewhat unsettling challenge in endodontics. Despite how critical they are to your daily practice, the scientific evidence that actually supports the diagnostic accuracy of many common clinical signs, symptoms, and tests, well, that's currently insufficient. This means those crucial decisions you make, distinguishing a treatable, reversibly inflamed pulp from one that's irreversibly damaged and needs a root canal, often rest on an evidence base that's, frankly, far weaker, potentially more biased, than we might instinctively assume or want it to be. It's a stark reminder that what feels right in the clinic, what seems to work, isn't always rigorously proven when you look closely at the literature.
Which means that you, the practicing dentist, you're often operating with a significant amount of clinical judgment, your intuition, your accumulated experience, in areas where the high-quality scientific data just isn't there yet to definitively back up every single choice you make. Now, this isn't a criticism of your skills at all, or your dedication, or the thousands of successful cases you've undoubtedly treated. Instead, it should be seen as a clear, really urgent call coming from the scientific community. We need more robust research, less biased, higher quality research in endodontic diagnostics. It truly underscores that blend of, art and science that still defines so much of what you do. And it highlights a critical area where the science really needs to catch up to the clinical reality you face every day.
And that future research absolutely must focus on developing and validating methods that can reliably tell us, can this vital but injured pulp truly be maintained? Can we save it with conservative vital pulp therapies like pulp capping or partial pulpotomy? It's about building a stronger evidence base for those conservative treatments that preserve the tooth's natural structure and function, often an ideal outcome for the patient. Or, if it can't be maintained, we need methods that establish with certainty that it must be removed and replaced with a root filling, ensuring the long-term health and stability of that tooth. And critically, beyond just snapshot diagnostic accuracy, future studies must assess the long-term benefit to the patient. That, after all, is the ultimate goal of any diagnostic procedure, isn't it? It's not just about getting the diagnosis right today, but about predicting and ensuring long-term success and patient well-being down the road.
So here's something to really mull over as we wrap up. If the scientific evidence is insufficient for so many of our go-to diagnostic tools and clinical observations, how much of our daily diagnostic confidence truly comes from rigorously proven, high-quality data? And how much stems from our clinical experience, our intuition, or maybe even just the way we've always done it? What specific clinical sign or test do you rely on most heavily in your practice? And how might this systematic review prompt you to perhaps reevaluate its scientific backing? Or even just think about what a truly high-quality study for that method would need to look like? The deep dive.